The normal reproductive years of the female are characterized by the monthly rhythmical changes in the rates of the secretion of the female hormones, together with the physical changes in the ovaries and other sexual organs. This pattern is called the female monthly sexual cycle, or better known as the menstrual cycle. The female hormonal system constitutes the hypothalamus, secreting gonadotropin-releasing hormone GnRH, the anterior pituitary gland, secreting the sex hormones follicle-stimulating hormone FSH and luteinizing hormone or LH, and the ovaries, secreting estrogen and progesterone. Hypothalamic GnRH causes the anterior pituitary gland to secrete progressively more FSH and LH, which in turn stimulates secretion of ovarian hormones, estrogen and progesterone. Due to this chain reaction, progressive increase of GnRH leads to the onset of the menstrual cycle, starting between the ages of 11 and 15 years. This period of change is called puberty, and the time of the first menstrual cycle is called the menarche. The menstrual cycle is divided physiologically into three sequential phases, namely the proliferative or follicular phase, the secretory or progestational phase, and the menstrual phase. The duration of the cycle averages 28 days and may be as short as 20 days or as long as 45 days, depending on the length of the follicular phase. The significance of this cycle is to normally release only a single ovum from the ovaries each month and to prepare the uterine endometrium in advance for the implantation of the fertilized ovum. The proliferative or follicular phase involves the proliferation of the uterine endometrium and lasts for an average of 11 days. This phase occurs right after the menstruation phase and before ovulation. The corpus luteum is responsible for the secretion of estrogen and progesterone, which acts on the anterior pituitary for the consequent decrease in FSH and LH secretion. In the proliferative phase, an almost complete involution of the corpus luteum eliminates the negative feedback effect of estrogen and progesterone on the anterior pituitary gland, initiating the secretion of FSH and LH. FSH and LH initiate new ovarian follicular growth consisting of theca interna cells and granulose cells, which then cause the secretion of increasing quantities of estrogen. Within 4 to 7 days after the beginning of menstruation, the high estrogen levels cause the stromal and epithelial cells of the endometrium to proliferate rapidly, causing the endometrial surface to be re-epithelialized. There is also a progressive growth of endometrial glands as well as new blood vessels. 2 days prior to ovulation, the high estrogen levels cause a positive feedback mechanism on the anterior pituitary gland, causing a 6 to 10-fold increase of LH and a 2 to 3-fold increase in FSH. This pre-ovulatory surge of LH converts the theca and granulose cells of the mature follicle to progesterone-secreting cells, causing a decrease in estrogen secretion. This decrease in estrogen after a prolonged excessive estrogen secretion, along with the beginning of progesterone secretion, prompts ovulation to occur. During ovulation, the mature Graafian follicle ruptures and the ovum is extruded into the abdominal cavity. First few hours after the expulsion of the ovum from the follicle, granulosa and pica interna cells change into lutein cells. They enlarge in diameter and become filled with lipid inclusions. This process is called luteinization, and the total mass of cells together is called the corpus luteum. The next phase is the secretory or progestational phase, which begins after ovulation, lasts about 14 days, and ends just before a menstrual period. With the release of the ovum from the mature Graafian follicle after the ovulation, the pituitary hormones FSH and LH cause the remaining parts of the follicle to transform into corpus luteum, which secretes progesterone and estrogen. Under the influence of estrogen, the cells of the endometrium proliferate, while progesterone causes marked swelling and secretory development of the endometrium. The uterine glands become coiled and tortuous and secrete a clear fluid. Secretory substances accumulate in the glandular epithelial cells, and lipid and glycogen deposits increase greatly in the stromal cells as well as in the cytoplasm. The blood supply to the endometrium increases, making the endometrium thick, edematous, and highly vascular. These changes in the endometrium take place in anticipation of the arrival and implantation of the fertilized ovum. The highly secretory endometrium contains large amounts of stored nutrients that provide appropriate conditions for implantations of a fertilized ovum during the latter half of the monthly cycle. On the other hand, estrogen in small amounts has a strong effect in inhibiting the production of both LH and FSH. In the presence of progesterone, the inhibitory effect of estrogen is multiplied. Similarly, the hormone inhibin, which is secreted along with the steroid sex hormones by the granulosa cells of the corpus luteum, also inhibits the secretion of FSH and LH. All these hormones together have combined negative feedback effect on the anterior pituitary gland and hypothalamus. This negative feedback causes the suppression of the secretion of FSH and LH, thus reaching its lowest level at about 3 to 4 days before the onset of menstruation. This negative feedback causes the suppression of the secretion of FSH and LH, thus reaching its lowest level at about 3 to 4 days before the onset of menstruation. Finally, the menstrual phase. The menstrual phase lasts for about 3 to 5 days and extends from the 1st to 4th day of the menstrual cycle. Because of the negative feedback effect of estrogen, progesterone, and inhibin on the anterior pituitary gland in the latter part of the secretory phase, FSH and LH levels decrease significantly. The decrease in the levels of FSH and LH causes the corpus luteum to regress, which in turn leads to diminished levels of progesterone and estrogen. This low levels of the two hormones leads to decreased stimulation of the endometrial cells, followed rapidly by involution of the endometrium itself. The fall in ovarian hormone levels also stimulates release of a uterine prostaglandin that causes vasoconstriction of the endometrial vessels, disrupting the blood supply to the endometrium. The subsequent reduction in oxygen delivery causes death of the endometrium, including its blood vessels. The resulting bleeding through the disintegrating vessels flushes the dying endometrial tissues into the uterine lumen. The same local uterine prostaglandin also stimulates mild rhythmic contractions of the uterine myometrium. These contractions help expel the blood and endometrial debris from the uterine cavity out through the vagina as menstrual flow. The entire uterine lining sloughs during each menstrual period, except for a deep, thin layer of epithelial cells and glands from which the endometrium will regenerate. Moreover, the decreased level of estrogen and progesterone releases the hypothalamus and the anterior pituitary from the feedback effect of these hormones. Pituitary secretion of FSH begins to increase again, while LH increases slightly later. Within 4 to 7 days after menstruation, the loss of blood ceases. By this time, the endometrium has become re-epithelialized. The quantity of estrogen produced by the ovaries must rise above a critical value if they are to cause rhythmical sexual cycles. However, failure to produce sufficient levels of estrogen may cause irregularity of menses or amenorrhea, such as in the case of hypogonadism. Failure of ovulation due to insufficient LH secretion at the time of the pre-ovulatory LH surge is also frequently associated with a shortened ovarian cycle.